Good afternoon, everyone, and welcome to course 5, believe it or not, of the Florida Certified Healthcare Financial Professional training sessions. We'll give it just another minute or so. We just opened up the line, but we are going to get started pretty quickly because there is a great deal of content in this section that we're going to want to make sure that we get through. One sec, the technical difficulties starting. This is always fun. So there you go. Remember to do that. As a reminder, we've said it the last 4 sessions. I'll remind you all again, for those of you that may be missing some sections, you do need to sign on to the HFMA website and go into the certification and sign up for the CHFP online course. There is a significant amount of material that we cannot go through. So we're going to go highlight the key knowledge conversation, and this should supplement you're taking the online course. There's a lot of other activities that you can take while you're doing that we will reinforce the concepts that we're going to go through today. So please make sure that you sign on for those as well. So this course today is going to take a closer look at the different ways healthcare bills are paid through the revenue cycle of a provider organization. And we'll also review 3 additional financial management concepts today: compliance, working capital management, and debt financing. And the learning objectives you can see here, we've already talked about, we've got here, is going to be both the concepts that we have on this slide, and then additional metrics on the management cycle, and then financing and capital equipment as well. So the revenue cycle, for those of you that have not lived the dream of revenue cycle, like many of us that have been in provider organizations for more years than we will share with you, is the flow of money between the patient, the insurer, and the provider of healthcare services, as illustrated here and diagrams more fully in course 1, Healthcare Finance, the Big Picture. However, the term revenue cycle is more commonly used to describe a more limited set of transactions. So it's the sequential interrelated processes a healthcare provider performs, beginning with scheduling a patient and ending with the healthcare provider getting paid. So in this course, we're going to use that term revenue cycle in this much narrower, more conventional sense. It's like when people ask me what I do for a living, and trying to explain that, it's typically, I'll think about when you schedule your visit at your provider. You go to your provider to get services. Your provider bills your insurance company, and then the provider may bill you. It's all those processes to get a provider paid is really what the revenue cycle is. So the guiding principles we're going to talk a little bit about here about price transparency. So that is important. So charge, right, is the dollar amount a provider sets for services rendered before negotiating any discounts. And the charge can be different from the amount paid. Certainly the price is the total amount a provider expects to be paid by health plans, payers, and patients for healthcare services. We know that a health plan payer is an organization that negotiates or sets rates for provider services, collects revenue through premium payments or tax dollars, processes provider claims for services, and pays provider claims using collected premiums or tax revenues. That many of us are in the provider space know it is an entity, organization, or individual that furnishes a healthcare service. And balance billing occurs, and we know that the No Surprise Billing Act, which we've had many courses on and presentations on over the last few months, or at least with the Florida HFMA chapter and many others, occurs when a healthcare provider bills a patient for charges other than co-payments, co-insurance, or any amounts that remain on the patient's annual deductible that exceeds the health plan's payment for covered services. So in-network providers are contractually prohibited from balance billing health plan members. But we do know, and what the No Surprise Billing Act is trying to do is address that balanced billing by out-of-network providers, also referred to again as surprise billing. So in healthcare, however, readily available information on the price of healthcare services that together with other information is not necessarily readily available or easy to use. But it helps divine the value of those services, and it enables patients and other care purchasers to identify, compare, and choose providers that offer their desired level of value. And then certainly value is a big conversation in healthcare today. So it's the quality of healthcare service in relation to the total price paid for the service by care purchasers. So when we talk about cost to the patient is the amount payable out of pocket for healthcare services, which may include deductibles, co-payments, co-insurance, amounts payable by the patient for services that are not included in the patient's benefit design, and amounts billed by out-of-network providers. So the cost to the provider is the expense, direct and indirect, incurred to deliver healthcare services to patients, and the amount payable to the provider or reimbursable to the patient for services rendered, and then the expense related to providing health plan benefits, things like premiums or claims paid. So the types of patient payments that we typically see, again, are those deductibles, co-payments, and co-insurance. The deductible is a predetermined amount that the patient pays before the insurer begins to pay for services. And many of us know we now have very high deductible health plans that's impacting care as well. Co-insurance is a percentage of the insurance payment made by the patient, with the amount paid by the deductible, typically going to a maximum out of pocket, which again, many of us know is much higher than we used to have. And then a co-payment is a flat amount that the patient pays at each time of service, typically emergency room visits, doctor visits, etc. It is important to remember that the patient is ultimately responsible for payment for services to a physician or hospital. A contract between an insurer and a provider may limit the ability for the provider to collect from a payment for denial of payment for covered benefits. So, however, the patient may have to pay a provider for any services not determined to be a covered benefit under the patient contract with the insurer, or things like Medicare, where we might have frequency limitations where you can only have a mammogram or some type of other diagnostic testings within a frequency time frame. So the term reimbursement is used to describe payment by an insurer to a hospital or a physician. This term is used because a physician or hospital provider will render services to a patient and then submit a claim to an insurer. Depending on the insurer, the service is provided in contractual terms between the physician or healthcare facility and the health plan. It may take from as little as 2 weeks to 2 months or longer to obtain payment for services. Current data from HFMA indicates that on average, it takes 53 days for the provider to be paid, which we all know that real-time adjudication is something that we all are looking to hopefully get at some point in time, because waiting 53 days on average is pretty significant. So the time span between submitting a claim and receiving payment can represent a financial challenge for a hospital or a physician. The average time it takes for a hospital or physician to be paid for services by a health plan is measured by the days and accounts receivable ratio. The physician or hospital has already paid for the resources needed in providing services to the patient, such as salaries or invoices for medicine and supplies. Therefore, any delay in receiving reimbursement for those costs from an insurer or a patient can threaten the financial health of the hospital or physician entity. And many of us that have been in the hospital space, provider space, understands that our operating margins are already slim, and trying to get your cash is Really important to get that in the door to keep those operation margins so we can continue to actually operate. So charges, a physician or hospital will set prices for services based on an analysis of operating expenses and expected income. The price set by a hospital or physician for their services is referred to as charges or billed charges. The charges by a hospital or physician represent the retail price and are usually compiled in a price listing known as the charge master. The actual payment received from an insurer, net of any discount, is referred to as net revenue. So depending on the circumstances for a specific provider in a healthcare marketplace, net revenue may be as little as 50% of billed charges. And for many of us that have been in the provider organization, we understand that Medicare and Medicaid reimbursement can be even less than that, sometimes at a negative ROI. Recall from course 2, remember this, is that in the aggregate, charity care and bad debt are excluded from net revenue. So the net revenue calculation is equal to price minus discounts to insurers, Medicare or Medicaid, minus charity care, minus bad debt. So per the AICPA, the following payment methodologies are commonly utilized by third-party payer health plans: fee for service, per diem, per case, episodic, capitation, risk-based contracts. And hold on one sec here. Diane, I have the right course up, right?
Are you referring to the polling questions?
Yeah, I'm just trying to make sure. I'm going to stop sharing really quick, guys. I apologize for that. I was working on next week's session. I just want to make sure I didn't pull up the wrong PowerPoint.
Yeah, I have the first polling question as slide 16.
Let me just double check.
Okay.
Yeah, I'm just making sure, guys. I apologize. That's which of the following would benefit most from a cost-based payment method?
Correct.
Awesome. Thank you. I do have the right slide deck, guys. Sorry. Just making sure I'm not confused over here. Okay. Let me
You're keeping us on our toes.
I was like, wait a minute. Am I confusing myself? Well, yes, I am. Okay. We'll go. Sharing slideshow. Okay. Okay, this is where we stopped. Okay. And just to recognize that each type of payment, they have different methods of structuring the payment to the provider. Each variation in the way a provider is paid creates different business incentives and risks for both providers and health plans. So fee for service, which many of us don't see often anymore, is a charge-based payment mechanism in which a provider is paid either list price, full charges, rarely, or a percentage of charges, more often, full charges less the discount, for the specific services rendered. The business incentive for a physician or healthcare facility provider under fee for service payments is to provide more units of service in order to receive more payments, which is probably why we are in some of the healthcare issues we have today. It is because of this incentive to provide more services that health plans began in the 1980s to create utilization management programs aimed at limiting the volume of services to those that were only deemed medically necessary. And many of you in the provider space are probably dealing with the entire prior authorization challenges that continue on. Even Medicare is putting those into play. So the definition of medical necessity differed among many health plans. And medical necessity guidelines in general were supposed to be based on best practices in medicine so that the patient received only those services needed to address the immediate illness or injury. Again, anybody who's dealt with prior auth medical necessity criteria understands there's really not a significant amount of commonality out there yet in the industry. So the Medicare program began with a payment mechanism particularly to healthcare facilities that has since been nearly eliminated from the healthcare industry. And that's cost-based payment, but you'll still have that out there. The only use of this method today is in a limited set of small rural healthcare facilities known as our critical access hospitals. This mechanism has rarely been used for physicians, and cost-based payment calls for the insurer to pay the healthcare provider based on the cost of providing services with a nominal allowance for margin. Again, this is not what you're seeing in your acute care hospitals or in your physician base, really limited to those critical access hospitals. So prospective payment. So a payment based on the patient's diagnosis is known as a diagnosis-related grouping, or DRG. DRGs are most widely used in healthcare providers, particularly acute care settings. A DRG is a classification of a disease or injury into one of approximately 750 different categories. The amount paid is a flat rate per discharge and adjusted based on relative severity of the patient's condition and resources used to treat the condition as determined by the DRG for that condition. What DRG really focused on too, if we think about all of the computer-assisted coding and all of the clinical documentation that's out there, is to ensure that coding is done correctly to get it assigned to the highest relative value in a DRG based on other comorbidities, etc. Resources, to treat that condition. So we talked about that. So in an effort to simplify the payment structure for healthcare providers and physicians, a per procedure payment mechanism may be preferable. In this situation, a health plan pays a specified fee for each procedure performed on a patient in a healthcare provider or ambulatory care facility or by a physician. Two per payment procedure approaches are used: ambulatory payment classification, APCs, and resource-based relative value scales, or RBRVs. So related to both the DRG and the per procedure payment methods is then also the case rate, which is a predetermined amount paid for a specified service or range of services. The difference between a case rate and the DRG is that the case rate encompasses a group of similar procedures, while the DRG can be specific to a unique diagnosis and may or may not include a procedure. An even simpler method of prospective payment is known as the per diem, or per day payment system, which is used primarily for payment to long-term care facilities. And as the name implies, a health plan reimburses a facility a fixed amount per day for a care to a patient. The rate may be higher or lower depending on the type of services the patient receives. That is, per diem or per day payments for an intensive care unit may be higher than the payment for a day in a medical surgical unit because of the intensity of the care. Another form of value-based payment is bundled payment, which is a form of episodic payment in which the health plan pays a single prospective rate for all services provided by the physicians, the healthcare providers, and post-acute care providers. And our key concept slide: which of the following would benefit most from a cost-based payment method? Actually, number one should actually say the healthcare provider. So the answers are the healthcare provider, the insurer, the patient. So answer number one if you think it's the healthcare provider, number two if it's the insurer, number three if it's the patient. Give everybody about 10 seconds more to answer that. So again, number one would be the healthcare provider. And we'll close that out, Diane. The correct answer is actually number one. The payment mechanism is advantageous for healthcare providers as there is a higher likelihood that all costs will be paid, and there is no incentive to be efficient in providing care, since costs will be reimbursed by the insurer. So that's where it is. Apologize, guys, for that confusion there on that slide. Okay. So because of the incentives, we talked about concurrent review. Concurrent review and why it was put into play along with utilization management. So concurrent review involves staff from the facility working with the health plan to review the medical justification and obtaining a certification of necessity for the patient's continued stay. This process can be resource intensive, as we know, for both the health plan and the provider. So as with other prospective payment methods, the facility bears the risk of the cost of care, possibly exceeding the per diem payment. So consequently, the facility has the incentive to limit cost and services provided to the patient to only those services deemed necessary for care during that occasion of service. So you have to then talk about kind of the reverse of, we went from concurrent review and limiting services to now a lot of the incentives for treating patients and discharging them too soon, and then not being paid if they are then again admitted. So trying to find a happy medium between, incurring your cost but not having the patient be discharged too soon is something that healthcare is still trying to do, because if they're readmitted within a certain period of time, you're not going to get paid for that admission either. So capitation, another common type of reimbursement is capitation. In many respects, capitation is the exact opposite of fee-for-service payments. Capitation pays a fixed amount per person per month to a provider in advance as payment for all services necessary to the patient. A capitation payment amount is normally expressed as a PMPM. Capitation is most common in relationships between primary care physicians and managed care plans, such as health maintenance organizations or HMO. However, capitation is also used for services from specialty physicians in some facilities. Capitation is sometimes referred to as a risk transfer mechanism, where the cost of care to a select group of patients is transferred from the health plan to the provider entity. If taken to the extreme, limitations on utilization of services may adversely impact the quality of care to patients. Conversely, providers do have an incentive to keep patients healthy to minimize utilization of more expensive treatments or services. And also, provider capitation provides a strong incentive to maintain close control over operating expenses, such as capitation payments are relatively stable from month to month. What distinguishes capitation from risk-based contract is that capitation arrangements, unless they contain risk pools, lack mechanisms for sharing the rewards of improved quality and lower cost between providers and payers. The incentive for the hospital is to limit services, while the incentive for the physician is to provide more services. The advent of value-based payment is a step towards aligning the incentive of hospitals and physicians and reducing the sources of this conflict. One form of value-based payment is bundled payment, in which the health plan pays a single prospective rate for all services provided by both the physician and the hospital, and the provider entities then equitably divide the payment amongst themselves. Under risk-based contracts, the payer, government or the commercial payer, and the provider share financially in both the risks and the rewards of providing healthcare services at a negotiated rate, giving all parties a financial stake in the contract's performance. Risk-based contracts generally overlay a conventional payment methodology, such as fee-for-service, per diem, per case, or episodic, with a retrospective settlement mechanism that shares savings, known as upside risk, or losses, downside risk, from the negotiated target. Risk-based contracts may also include provisions that reward providers for achieving certain non-cost related metrics, such as quality goals, or penalize them for not meeting or reporting them. So Medicare Shared Savings Accountable Care Organizations, MSSPs, ACOs, established by the Affordable Care Act, and the Quality Payment Program, or QPP, established by the Medicare and CHIP Reauthorization Act, are examples of risk-based contracts. So the rank from lowest to highest risk is shown on that chart, from the least risk to the greatest risk to healthcare providers. So if I'm paid a charge-based payment or charge-based payment, I have less risk. Capitation is the most riskiest model out there for providers to be reimbursed. And generally speaking, prospective payment methods or capitation create risk for physicians or hospitals. These methods also change some of the ways that a health plan would manage the risk of healthcare cost. So a summary of the incentives and risks of the type of reimbursement is shown on the slide. As long as both parties have a solid understanding of the risks they undertake with prospective payment arrangements, a business relationship based on this type of payment can be mutually beneficial, yielding a reasonable income to both health plan and provider. So key concept slide, APC and RBRVs are both approaches to what type of payment techniques. Per procedure, per diem, DRG, case rate. Okay, Diane, let's close that out. We do have a lot of material, so we're not going to keep those open too long. The correct answer is procedure-based payment techniques. Okay. So the processes for billing and collection are often combined into one overall description known as the revenue cycle. So the revenue cycle in healthcare can be broken into 3 different phases that cross between the provider and health plan insurer entities. And the overall concept of the revenue cycle, although it's simply not as easy and simple as the diagram, is illustrated there. Each phase consists of several steps, beginning with activities prior to the patient visit, activities during the patient visit when the patient receives care, and then activities that occur after the patient receives services in an attempt to collect the balances due. So pre-visit activities, they are intended to facilitate the gathering of information necessary for serving the patient during the visit and for billing and collection for services after the visit. Approximately 60% of all of the information needed to serve the patient during the visit and bill for services is collected before services are provided. It is essential that managers pay particular attention to the accuracy of data gathering and processing at these early stages of a patient visit. So pre-visit, we're doing patient scheduling. During the scheduling transaction, basic demographic data about the patient and his or her payment resources is collected. This data should be recorded as part of creating the patient account when the patient is scheduled. Since data on the patient's payment resources is collected when the visit is scheduled, the provider can then contact the patient's health plan and complete an essential step, and that is eligibility verification. The eligibility verification step can also advise the provider of any out-of-patient amounts to be collected when the patient comes for registration prior to service or at time of service. And this is known as pre-service or point-of-service collections. And we all know it is far more difficult to collect these amounts from the patient after services have been rendered, so it is essential to make an effort to collect the patients at this point. So once the patient is registered, a medical record should be prepared for documenting the services provided to the patient and then the findings regarding the patient's medical condition. Data from the medical record can also be used to support any additional utilization review requirements of the health plan, such as certification of additional days or demonstration of the need for an additional surgical procedure or prior authorization. At the same time, documenting services in the medical record may assist staff in completing charge capture, where the individual's items making up the total charges on a patient account are compiled. The items added to a patient account at charge capture are recorded at the charge master price so that the compiled claim is prepared using billed charges. It is a good practice to verify the charges on the patient account against data in the medical record to verify that the items claimed for payment were documented as provided to the patient. We all know what RACs and audits and ZIXPICs and all those are there for, right? This would ideally be done at the time the patient visit ends at discharge. And then again, any information needed for medical record completion would be gathered in the final phase of this process. Ideally, we said the medical record should be completed at the time of discharge or as quickly as possible thereafter, depending on the nature of services provided to the patient. A physician may need to review all documentation contained in the medical record to prepare a final summary of care provided to the patient for use in the billing processes. Preparation of this document, known as the discharge summary, is a common point of delay in the timely completion of this process. There are many reasons for such a delay, which often are avoidable by close attention to ensure the physicians get the data they need as soon as it is available. We get into the coding process. It analyzes the medical record to assign codes that describe the diagnosis of the patient's condition and the procedures performed during the patient's visit. Diagnosis codes are a part of the International Classification of Diseases, or ICD, published by the World Health Organization. The United States converted to ICD-10 on October 1st, 2015. Procedures performed in a physician office or outpatient settings are described by the current procedural terminology, or CPT codes, published by the American Medical Association. Procedures performed in an inpatient setting are also described by ICD-9 codes. Examples of ICD-9 codes and CPT codes are on the slide for your review. So the billing step entails compilation of charges, diagnosis, and procedure data from the medical record. The formal claim should also include demographic and payment information. It's sent to the health plan. Any prior authorization or utilization review information required by the health plan must also be included in the claim. It should be the objective of a healthcare provider or physician clinic submitting a claim to have all data available that is needed to prepare the claim, compile that data into the claim, and then send the claim to the health plan in the shortest amount of time possible, but is also as clean as possible to avoid downstream rejections and downstream denials. So since the healthcare provider or physician has already incurred those costs to provide the services, the faster that a payment can obtain, the sooner the funds can be used to treat other patients or otherwise benefit the provider and the community they serve. So key concept slide. Katie is preparing a claim for submission. Which of the following items would not be needed in order for her to send a clean claim? Information identifying the patient, copies of the patient's previous medical records, data on the patient's diagnosis and any procedure performed, and information identifying the treating provider. Okay, let's close that out. Correct answer, you got it. Copies of the patient's previous medical records. All of the rest of the data is required to actually submit a claim and a clean claim. Typically, if they want patient's previous medical records, they'll deny the claim, request that information, or send a request for information and pen the claim until you get it, but you don't require it to get a clean claim out the door. Okay. So payment processing. On receipt of the claim, the health plan will record the claim in its inventory of claims pending processing in a step known as claim logging. It is customary with the use of electronic billing for the health plan to send an electronic acknowledgement of the claim to the provider. As the claim is being adjudicated, the first step is to verify that the patient was eligible for coverage by the health plan on the date of services recorded on the claim. This is important because a patient's eligibility for coverage may change, as we know, and record keeping by the health plan may lag behind the actual transaction. Once the claim has been checked for eligibility, the billed services are checked against the insurance plan's list of covered services. For example, many elective cosmetic surgery procedures are not covered by health insurance plans. If the services described on the claim are cosmetic surgery and no evidence is provided to indicate the procedure is medically necessary, then the claim is typically denied for payment as a non-service. Once the payment amount has been determined, the remittance is prepared and queued for release on a specified future date, i.e. Medicare has a 21-day payment floor, I think still, or been a 14-day payment floor. Somebody can correct me on that one. But normally the payment is made through electronic funds transfer to the bank of the physician or health provider submitting the claim. And then when the payment is sent, the 835 record remittance advice is also sent. So in today's healthcare industry, a claim for payment to a health plan is typically submitted electronically through a standard format developed by the ANSI, American National Standard Institute. There are two common formats used in healthcare billing and collection transactions. The claim for payment is referred as the ANSI 837 IRP, or more commonly known as the 837 record. And then the remittance advice sent from the health plan to the provider explaining the payment decision is also a standard ANSI format referred to as the ANSI 835 or the 835 record. Providers will receive claim denials. Happens every day, each day, unfortunately. Some are unavoidable, but most can be prevented. Most denials are the result of an error in an earlier phase of the process. The accuracy of data gathered before and during times of services are provided requires attention by managers, as accurate data is necessary for an accurate and timely claim submission process. Avoiding errors before a claim is submitted eliminates or reduces delays in payments from a health plan. Providers must move to a denial prevention strategy by trending and determining root causes and addressing those and moving forward. So payment posting, when accomplished through electronic remittance posting and accompanied by electronic fund transfer, is usually a straightforward process. It is the best practice for a member of the PFS department to verify that the payment received is correct in contract with the health plan. Many refer to that as payment variance or use contract management tools to manage things like underpayment. In some cases, the patient may be responsible for an amount after the health plan pays. The patient is billed for the balance due, and if no payment is received, staff should contact the patient and attempt to collect any remaining balances due. As many of us know, many providers outsource that self-pay collection strategy to vendors that support those processes. Key concept slide. Paul reviews another claim that has been denied. A problem with coding accuracy was the reason for the denial. Which of the following would be an obvious error in coding accuracy? Showing a hysterectomy for a male patient, including a lung procedure with a patient having a diagnosis of pneumonia, and having a patient with multiple procedures included in the same claim. So I am going to hope that this is one that was pretty obvious when you answer this. So let's close that down, Diane. The correct answer is showing a hysterectomy for a male patient. So you can have multiple procedures included in the same claim. You may have to have required things like modifiers and et cetera, but it is not uncommon to have those types of procedures in there. Okay. In addition to monitoring the time from patient discharge to the time that a claim is submitted to the health plan, managers must be aware of how long it takes for a claim to be paid by the health plan. The net days in receivable calculation is a good measure of how effectively the organization collects amounts due from patients and health plans. So please refer to the HFMA map keys in the resource section on the e-learning capabilities for more information on the published revenue cycle metrics as well. While it is important for managers in a physician clinic or health provider to monitor processing of receivables, a health plan also has an incentive to monitor the inventory of claims awaiting adjudication. It is important for the health plan to pay its claims on a timely basis to maintain compliance with contracts with healthcare providers and physicians. It may be difficult for a health plan that is slow in paying to retain enough providers to meet the needs of its members. And many states have enacted timely payment guidelines that if it's not paid within, say, 30 days, there is a penalty or a fee assessed to the actual payer at that point in time. So a key concept slide again, which of the activities below is not a part of the pre-visit portion of the revenue cycle? Diana, are we having problems with the polling questions again? There we go. No, slide 38. Did we not? Did I not point that one out to you? Might have been my fault.
No, I didn't have that one. I had 36 and then 43.
Okay, sorry about that. That's okay. So which of the activities below is not a part of the pre-visit portion of revenue cycle? Obviously, it makes sense. You're going to schedule the patient. You're going to verify eligibility. You're going to pre-certify that patient in advance of treatment. You're going to register that patient. So the answer is coding, which involves capturing the data to create the charges and occurs as the patient receives care. It is not part of the pre-visit activities. Okay. Compliance, we all familiar with compliance programs. Providers of healthcare services to beneficiaries of federal healthcare programs such as Medicare, Medicaid, CHIP, and TRICARE must comply with those statutes and regulations governing those programs. Providers that bill federal programs must have a compliance program with the following features: a chief compliance officer, a hotline or other anonymous method to communicate complaints, written complaint policies and procedures, ongoing training for all personnel, disciplinary guidelines and enforcement, and internal monitoring and auditing. Fraud is the intentional deception or misrepresentations of facts for gain. Fraud carries criminal penalties. The burden of proof is high, beyond a reasonable doubt. Abuse involves unintentional errors that are inconsistent with accepted sound medical, business, or fiscal practices. Abuse carries civil monetary penalties, and the burden of proof is much lower. The chief enforcement vehicle of the federal government is the False Claims Act, which allows the U.S. Department of Health and Human Services to recover monetary damages of up to $11,000 per false claim. A whistleblower is someone who discloses information he or she reasonably believes evidences a violation of any law, rule, or regulation, gross mismanagement, a gross waste of funds, an abuse of authority, and a substantial and specific danger to public health and public safety. HIPAA, or Health Insurance Portability and Accountability Act, protects patients' health and demographic information, protected health information, or PHI. Most of us are very familiar with HIPAA. It applies to covered entities, health plans, clearinghouses, and healthcare providers. It requires signed authorization by the patient for any use or disclosure not explicitly required or permitted. And it limits disclosures to minimum necessary information. Stark 1 and 2 rules prohibits physician self-referrals for health services to entities with which the physician or their family member has a financial relationship. And then anti-kickback statute makes it a criminal offense to knowingly and willingly offer, pay, or receive any remuneration for, tough words here, are in order to induce referrals. So which of the following is not a law or regulation which healthcare entities must comply? HIPAA, CHIP, Stark 1 and 2, anti-kickback statutes. Close this one up pretty quickly because this should be pretty easy. Okay, close that up, Diane. The actually correct answer is CHIP. That is the Children's Health Insurance Program, or commonly referred to as CHIP, which is a federal government plan and also a state-funded plan. Stark is a regulation that elicits about referrals to either a physician-owned or family-owned entity. It'd be like a husband sending or patient to their wife's specialty program would be considered Stark 1 and Stark 2. Okay. So working capital management, it is also critical for attention to be paid to the amount of cash on hand and the use of cash while the provider awaits reimbursement for services. The difference between current assets, cash, receivables, and inventory, and current liabilities, salaries payable, and accounts payable is referred to as working capital. Essentially, working capital entails collecting receivables as quickly as possible while making payments for salaries and other expenses on the date due and not before. A common metric for monitoring inventory levels is the day in inventory ratio. Hospital use these ratios frequently, as do large physician clinics. It may not be relevant to a small physician office or a health plan that maintains only a minimum inventory. Days and payables ratio is also an important tool. The health plan has a large amount of payables on hand in terms of claims awaiting adjudication. Health plan managers must be sure that they are timely paying invoices presented for payment. Many of us say insurance companies don't. But it is equally true for a physician clinic or hospital purchasing supplies on trade credit. Timely payments are essential to maintain access to trade credit, which allows the hospital or clinic to finance supplies used to provide care. So there are additional financial resources. Short-term sources of financing entail different types of debt. The most common form of short-term debt in a healthcare organization is accounts payable. Accounts payable are a form of trade credit where a supplier delivers goods to a buyer but delays on those supplies for a short time, usually about 30 days. This delay in payment for supplies is a form of debt that can free up cash for other uses such as payment of salaries. Some businesses also acquire additional short-term debt through a line of credit with their bank. A line of credit is like a credit card through which the organization can draw funds as needed to meet immediate cash needs. Long-term debt is almost always secured with some asset of the business as a collateral for the debt. This debt is usually in the form of a mortgage or a bond issue. A longer-term rental agreement is referred to as a lease. A lease may be structured as either an operating lease or a capital lease. An operating lease is essentially a long-term rental of facilities or equipment. A capital lease is similar in many respects to a mortgage in that the lessee makes a fixed monthly payment to the lessor for use of the asset. So the legal form of an organization for a healthcare business will determine its ability to obtain financing. A 5013C not-for-profit entity is an organization organized and operated exclusively for religious, charitable, scientific, literary, or educational purposes. They are exempt from federal income tax. They can obtain equity capital only through gifts and donations. A for-profit entity does not enjoy the same tax advantage. Donations are not tax deductible. However, they can raise capital through the sale of stock. Okay. So as I said, we had a lot of material in this section. So I'm going to stop there and see if there are any questions in the chat, or if anybody wants to review any materials or have any questions immediately, feel free to come off of mute, join the party. As a reminder, all the materials will be available on the Florida HFMA website. So feel free to download those as you go through your study sessions. The recordings will be on the Florida HFMA YouTube channel. So as you're reinforcing these concepts, feel free to go in and re-listen. You should all have my contact information. So if there's any questions, we will be putting that out there. Our last session of the first course of the module for CHFP will be next week. We do have another session after that to talk about, there are two components of the CHP. If you don't know that yet, you've got to take the one component, which is these 6 modules or 7 modules that we'll go through. And then once you pass that, you move into the healthcare of business, which is a different module, and we'll walk through that. So there are 2 components to obtain your CHFP certification, and we'll go through that as well. So I'm assuming there's no questions in the chat.
Nope, no questions.
Awesome. All right, well, we'll stop sharing, guys. If you need anything, please let me know. Hopefully this was helpful for you all, and look forward to seeing many of you get certified, hopefully in the next few months. All right, thank you for your time, and we'll be talking to you soon. Take care. Bye.